informed that there are just the best dermatologists, huh? Remained. Okay, okay. Okay, so today I will speak about dermoscopy by starting from colors. I didn't do it on purpose, but on the first line of the title, there are all the colors we can see in dermoscopy in inflammatory diseases. So, but we will see them later. So, let's start with this. This is not dermoscopy, of course, but I would like to ask you, what do you see? Huh? A sad young girl. I see an old woman. You cannot see. What do you see? A dog. No, no, there is no dog. Come on. There is no dog. There is an old lady, right? And I see the old lady. This is the eye. This is the nose. Okay, this is the chin. But there is also... Yes, but this is also the chin of the old lady. And this is the neck of the young lady. So everyone sees what he wants to see. Okay. And this is also in dermoscopy. For example, here, what do you see? Scales. Then? Pigmentations. Vessels. Okay. Okay. May we do the diagnosis? No, I don't think so. But the problem is that, especially when it comes to inflammatory lesions, we may, miss something. Okay, you missed something indeed, but we will see. So for this reason, we released this paper, which is very important. This is the standardization of the basic parameters that we can see in dermoscopy of inflammatory conditions, okay? So we have our alphabet, okay? And we have 5 parameters. Vessels, scaling, follicular findings, very important, other structures, it means colors, and then specific clues, okay? 5 things, Okay. So now let's come back to this image. Do we see vessels? Yes, here, for example, here we have a linear curved vessel. Do we see scales? Yes, of course, a lot of them. Do we see colors? Yes. Brown, black, okay. Do we see follicular findings? Yes. What? Follicular plugs. Okay, but you didn't see it. And this is very important, okay? If we use a standardized approach, we can see everything. So what's the diagnosis? Follicular plugs, in this context, disco lupus. Very good, very good. But without seeing the follicular plugs, it would have been difficult to make the diagnosis on dermoscopy, of course. Very well, very well. Disco lupus. Okay, so these are the 5 parameters. Which one is the most simple to be seen, in your opinion? Best colors. Good. Colors. Right. Otherwise, I would have changed the title. Yeah. Okay, colors. But yeah, I think that we all agree that this is pink. No, yellow. Okay, okay. Perfect. So these are the colors that we can see on dermoscopy. So there are 7 colors, okay? Each of them corresponds to a specific histological background, okay? We are used to see, of course, gray, brown, and blue in melanocytic lesions, but in inflammatory conditions we have other colors, okay? For example, yellow corresponds to the presence of lipids. Okay, and it's very important to consider the dermoscopic histopathological correlation when it comes to dermoscopy, and especially when it comes to dermoscopy of inflammatory conditions. Okay, so these are the dermatoses which are typified mainly by each of the colors, but we will speak about many conditions. Let's start from orange. I think that orange is the most popular color when it comes to dermoscopy inflammatory conditions, because for many years, this color has been associated with granulomatous conditions, okay? When we see orange, okay, it's a sarcoidosis. It's not like this, but anyway. So let's see orange. The basics of granulomatous diseases, okay? We have orange because we have a very compact, dense cellular infiltrate in the dermis, okay? We can see orange even if we push a slide on the skin, on the lesion. Okay, great. The question now is, may dermoscopy help us distinguish the subtype of granulomatous condition? The answer is yes and no. We will see. For example, here we have this patch and this dermoscopic image. Of course, we have some orange areas, okay? So it could be a granulomatous condition, okay? But we have this very nice vascular pattern, typified by these serpiginous branched vessels, okay? This is necrobiosis lipoidica. This vascular pattern is typical of necrobiosis lipoidica, and it's not usually seen in other granulomatous conditions, okay? We have to consider this because sometimes we have some cases of necrobiosis lipoidica which are not very typical from a clinical point of view. But on dermoscopy, they always show this vascular pattern associated to orange areas and also to yellow areas, because in necrobiosis lipoidica, we also have lipids in the dermis, okay? Great. Then, we have to pay attention not to confuse necrobiosis lipoidica with this subtype of annular granuloma, which is annular elastolytic giant cell granuloma, which is quite common, actually. The difference is the reticular vessels in the center, okay, and the presence of orange areas at the periphery, okay, of the lesion. That's the pattern of this type of granuloma annulare, okay? Great. Which one is necrobiosis lipoidica? That one. Okay. Okay. Yeah, they look very similar between each other. Come on. This is why I tell you, clinical examination might not be enough sometimes to make the diagnosis. If we combine dermoscopy, we can improve our diagnostic power. So, you said that one. Okay. Brava. Brava, brava. And this one is the other condition. Okay, because we have the reticular vascular pattern and the orange area at the periphery. Okay, you don't need dermoscopy. Okay, I got it. On the other hand, in this case, we have these serpiginous vessels with branches. Okay? Great. Great, great. So, this is another granulomatous condition. Okay? We can, of course, have an idea on the diagnosis. Which is the idea? Rosacea. Very good. Rosacea, very good. We have orange areas, and we have our reticular purple unfocused vessels, the so-called vascular polygons, okay? The presence of vascular polygons are typical of granulomatous rosacea, okay? Great, and this? No, discoid lupus, okay? We have, you're right, we have plugs, follicular plugs, okay? But we also have orange around each follicle. No? No? It's acne agminata, or lupus miliaris disseminatus facie, which is basically a granulomatous reaction around the follicle, okay? A damaged follicle, okay? This is not so rare, but the dermoscopic pattern is very characteristic. So the follicular plugs and orange around the follicular plug. Perfect. Then we have this. What's? Okay, it could be, but we have I'll give you a tip. We have plugs, yellow tears. No, it's a granulomatous condition. So follicular plaques, leishmaniasis. Okay, when we have orange areas and follicular plaques, we have to think about leishmaniasis. Because in disco lupus, we have, of course, follicular plaques, but we don't see orange because it's not a granulomatous condition. Okay? Perfect. And this is from Philippines, I think, yeah. Huh? No. Here, you can see that we have a reduction of skin appendages. It's a granulomatous condition typified by a reduction of skin appendages. Leprosy. That's right, leprosy. In leprosy, the clue is the lack of skin appendages. So we see less follicular ostia and less eccrine glands ostia. Okay? Because we have a destruction of skin appendages in leprosy. So orange plus a reduction of skin appendages. Okay? Great. This is simple. Huh? This is simple even from a clinical point of view. I mean, granuloma annulare, okay. The clue of granuloma annulare is the presence of blurred vessels. Usually, when it comes to granulomatous conditions, the vessels are very sharp, okay? Because the cellular infiltrate pushes the vessels upwards, so towards the surface, thus appearing more focused. But in granuloma annulare, we don't have a very compact, okay, cellular infiltrate. So this infiltrate is not able to push the vessels upwards. So they look blurred, okay? Perfect. So, and this, I've spoken about everything except sarcoidosis. Yeah, actually in sarcoidosis, we don't have a very specific clue, okay? Usually we have to rely on the vascular pattern. Vessels are very, very sharp, as I told you before, and they are small, okay? Perfect. The pattern is the same on dermoscopy, even though if we may have different presentations, you know that sarcoidosis may have different presentations, for example, papular sarcoidosis, on dermoscopy we still have the same dermoscopic pattern, orange plus focused vessels, okay? Small focused vessels. Even in this case, this was a single lesion. Huh? Difficult from a clinical point of view, but we see orange, we see the orange is here, here, and we see the sharp, small vessels, okay? It could be also a tumor from a clinical point of view, but on dermoscopy, we can have an idea on what it is. The plaque-type sarcoidosis, still we have orange and these small focused vessels, okay? Great. Sarcoidosis versus lupus vulgaris. Honestly, we cannot discriminate these two conditions on dermoscopy. They look the same, basically. We have orange and small focused vessels. But, actually, in dark phototypes, there is a difference, because in lupus vulgaris, we have more fibrosis, okay? So we see more bright white areas compared to sarcoidosis. But this is just in skin of color, okay? Great, great. Another thing we have to know, I told you that sarcoidosis, granulomatous conditions are associated to orange, but in very dark phototypes, we don't see orange, we see yellow, because it's orange on brown, which gives yellow, okay? Perfect, so, to summarize, granulomatous dermatosis, orange areas, okay, or yellow in very dark skin types, okay. Small-sized focused vessels, we have to think about sarcoidosis and lupus vulgaris. Blurred vessels, granuloma annulare. Then follicular plaques, leishmaniasis, okay? Then we have reduction of skin appendages, leprosy, focused serpentine branching vessels, and yellow we have to think about necrobiosis lipoidica. Then reticular vessels with a peripheral orange area, we have to think about annular elastolytic giant cell granuloma. Granulomatous rosacea is typified by polygonal blurred vessels, okay? And finally, acne acuminata, follicular plaques surrounded by an orange area, okay? Huh? Now you can take the picture. Okay, so let's practice. Do you have an idea about the diagnosis here? Single lesion. Sarcoidosis, yes, of course. Sarcoidosis may look like everything, so it's never a mistake. Let's take a look at dermoscopy. We have orange. We have plugs. So, leishmaniasis, correct. Leishmaniasis, perfect. And here, this was very difficult, honestly. Huh? Sarcoidosis. Yeah, sarcoidosis is never a mistake. Okay, sarcoidosis, I agree with you, sarcoidosis, but it could also be, lymphomatoid papulosis, for example. Let's take a look at dermoscopy. What is this? What? We have yellow. Yeah. We have, serpentine branched vessels. This is necrobiosis lipoidica because, we are used to see the typical plaque on the books, okay? But, at the beginning, it may, look like this, just small papules, okay? But on dermoscopy, the pattern is the same, so we can recognize it. Perfect. And this, yeah, so I agree with you. This time I agree. Sarcoidosis. But we have some yellow, but look at the vessels. They are serpentine vessels and branched. So we just, what? Actinic keratosis. Yeah, it's, it's necrobiosis lipoidica, okay? Because, there are many cases that may present with an atypical clinical pattern, okay? So we have to combine the clinical data with dermoscopy. This was a young lady suffering from diabetes type 1, okay? Okay, this. Porokeratosis. Then? Pityriasis, like an odus. And sarcoidosis? No, it cannot be sarcoidosis, come on. Huh? No. It cannot be sarcoidosis. Huh? What do we have? We have orange areas, sarcoidosis, and small focused vessels. This was sarcoidosis. You always have to say sarcoidosis. Come on. Sarcoidosis. Sarcoidosis may present, with several clinical patterns. Also, as a papulosquamous dermatosis. Okay? Great. Now, we have this case. This is difficult. It could be, of course, sarcoidosis. I agree. It could be lymphoma, pseudolymphoma. Okay. Which color do we see? Orange. No, yellow. Come on, it's orange. It's orange. Okay. And then, what do we see? Vessels, yes. There are some polygonal vessels, but he also has maybe a little bit of rosacea. They are not significant. Okay, we don't have relevant vessels, I'd say. Okay, just a little bit of unfocused vessels. And as I told you before, in granulomatous dermatosis, vessels are always focused, sharp, except from granuloma annulare, but this is not granuloma annulare, of course, okay? This is granuloma facciale, which is not a granulomatous dermatosis, because what's this? Yeah, leukocytoclastic vasculitis, okay? So it's not a granulomatous condition, okay? So this is to say that orange may be seen in granulomatous conditions, but also in other conditions, okay? We have two groups of dermatosis characterized by orange on dermoscopy. The first group are dermatosis characterized by dense cellular infiltrates. So sarcoidosis, granulomatous conditions, but also, amyloidosis, lymphomas, pseudolymphomas, okay, which are, of course, less common. And then this is another group of conditions typified by orange, which includes dermatosis characterized by hemosiderin deposits in the dermis. Because, hemosiderin is iron, so it's a rusty color, okay? But the difference is in the vessels. In the first group, the vessels are very focused, because the infiltrate pushes the vessels upwards. In the second group, the vessels are blurred, okay? This is the difference. This is very important, okay? Because we don't have a very compact cellular infiltrate in those dermatitis, okay? Great. And another thing to know is that orange is not always present in granulomatous dermatosis, okay? Because the granulomas may be deeply located, for example, in, deep granuloma annulare or rheumatoid nodules, okay? Or sometimes we have significant epidermal changes which cover the orange color, okay? For example, in leishmaniasis. Perfect. And also in granuloma annulare. As I told you before, vessels are very blurred, okay? We may see orange, but just in the palisading granuloma histological subtype, because we know that there is another histological subtype in granuloma annulare, which is the interstitial variant. Here we don't have a compact cellular infiltrate, so we don't see orange, okay? Great. So, main dermatosis typified by orange color related to hemosiderin deposits. This is granuloma facciale. We already saw this. We have some other clues, which are blurred vessels, and most importantly, dilated follicular openings, which sometimes may be also appreciated on clinical ground, especially on the nose. But of course, it's not pathognomonic. Then this, what's this? Simple. We have a rusty background and purpuric spots. Purpuric capillaritis. Yeah, this is like an aureus. Huh? Very simple. Schamberg disease, all the capillaritis. Yeah. Okay, purpuric spots. And then we have also pityriasis lichenoides chronica. Also pityriasis lichenoides chronica may show orange because we have hemosiderin deposits in the dermis. But the vessels, take a look at the vessels, are very blurred. Okay? Great. And then this. This was a nice case. This man came for this eruption, no symptoms. Orange. The lesions were all the same, monomorphic, okay? Do you have any idea? Huh? No, it's orange. It's orange with just a few dotted vessels. We have to think always about a disease, which is another great imitator. Syphilis. Good, syphilis. Syphilis. Even in syphilis, we have hemosiderin deposits, so we see orange. Syphilis, correct. Syphilis, we see orange. Another case. Syphilis. Which one is syphilis? No, both. This one, orange. Okay, because the peripheral collarate, the B8, collarate of B8 collarate, is not pathognomonic, come on. It may also be seen in psoriasis. This is psoriasis, okay? It's the color of the background which may help us make the diagnosis, okay? This one is syphilis. Okay, and also this disease may show orange. This is an atypical presentation, actually, of the disease. We have follicular orange areas with peripheral dotted and linear vessels. This is PRP. Also in PRP, we can see orange, okay? Great. As you can see here, this is an erythroderma, which is, come on, difficult to make the diagnosis. Okay, we have the spared hairs, whatever. But on dermoscopy, we have orange, okay? And we have these spared hairs, okay, with reticular vessels, okay? Even here, which one is PRP? Difficult. This one, that one, this one. Okay. Good. Good. This one. Still we have orange. This is psoriasis. We see just the dotted vessels. Okay? Okay. So we have to think about these 4 conditions when we have in front of us a papulosquamous dermatosis showing orange. So sarcoidosis, in which we have focused, sharp vessels, okay, so we can distinguish it. And then these other 3 conditions, PRP, pityriasis lichenoides chronica, and syphilis. Honestly, from a dermoscopic point of view, it's very difficult to differentiate these 3 conditions, so we have to rely on clinical data and the medical history, okay? But these are the conditions we have to think about when we have orange. Okay, now, granulomatous or not? Are you ready? Okay. So we have this 67-year-old female, 2 months, asymptomatic, treated with metronidazole gel with no improvement. Okay? From a clinical point of view, I would think about rosacea. It's reasonable. Lupus. Sarcoidosis. Sarcoidosis. Okay, let's see. Okay. Here we have orange. It's not very well visible, but there is orange. Nothing else. Nothing else. So it's unlikely the diagnosis of sarcoidosis because we have sharp vessels. So we are in the other group of conditions in which orange is due to hemosiderin. So on the face, no Morbihan, no. Granuloma facciale, yeah, granuloma facciale, okay? An atypical presentation, I agree with you, but this was a granuloma facciale. Of course, we took a biopsy. Okay, and this one, poor guy. His wife brought him, she was desperate because, okay, 64-year-old male, 4 months, asymptomatic, treated with topical steroid with no improvement. This is difficult. It could be sarcoidosis. It could be psoriasis. Do you have any other hypothesis? DLE? Okay, DLE. Lupus? Okay. Okay, dermoscopy. Okay, we have a lot of pustules, hyperkeratosis, and we have these structures coming from the Demodex. Another friend, Demodex. Yeah, demodicosis. We have these protruding follicular plaques, which is a mixture of keratin plus the mites. Okay. This one. 74-year-old female, 3 months, asymptomatic, treated with topical steroids with transient improvement. Come on, this is psoriasis. No, this is psoriasis, come on. Lupus, pseudosporiasis. Yes, you're right. Because we don't see the dotted vessels of psoriasis. We see orange plus focused branching vessels. You can see that sarcoidosis may look like everything, okay? But on dermoscopy, we always have the same pattern. Yeah, but you are too good. You are too good. Okay, sarcoidosis. Okay, now, just a few words on these three colors, okay? Brown, gray, and blue. From an histological point of view, these colors are due to the presence of pigment in the dermis or epidermis, which is melanin or melanophages and ochronotic pigment, okay? Of course, the color depends on the deepness, okay, of the pigment deposition. Brown if the pigment is located in basal cell layer or superficial dermis, gray if it's in the papillary dermis, and blue if it's in the reticular dermis, okay? Great. The morphology of the colors may be without any structure, structureless, okay? Dots and globules, lines including network, and circles, okay? So, we will address extrafacial areas and face. Okay, these are extrafacial areas, okay? I divided the conditions according to the clinical morphology for a practical purpose. Okay, when we have discrete, so not confluent, pigmented macules and papules on the trunk and limbs, we should think about lichen pigmentosus, ashy dermatosis, and urticaria pigmentosa, okay? But as you can see, these are two different conditions, but they look very, very similar between each other, okay? Perfect. Lichen pigmentosus, ashy dermatosis, urticaria pigmentosa, still we are in the same group, so I don't know if you have an idea on the diagnosis, but we will see these cases later. Okay, let's see the dermoscopic clues of these three conditions. In lichen pigmentosus and ashy dermatosis, we have dots, okay? Because we have pigment incontinence in the dermis, okay? The difference is the color of the dots. In ashy dermatosis, the color is blue or gray. In lichen pigmentosus, the color is brown, okay? Because the pigment is located more superficially, okay? And also the size, actually, in lichen pigmentosus, the dots are a little bit bigger because they are closer to the skin surface, okay? What about urticaria pigmentosa? What do we have on histology? Yes, okay, mast cells, but we have a pigmentation of the basal cell layer. So we see a network. Or sometimes we see structureless brown areas when we have a lot of pigmentation, okay? Great. So let's come back to these cases. I don't know if you have any hypothesis about this, for example. This is more brown. Okay. Could it be lichen pigmentosus? Yes. Could it be urticaria pigmentosa? Yes. Maybe not ashy dermatosis because, you know, lesions are bigger and bluish. Okay. Let's take a look. The dermoscopic pattern is completely different. Yeah, urticaria pigmentosa, the network, the brown network. And here we have dots, which are brown. Lichen pigmentosus, lichen pigmentosus. Also, maybe. Okay, here. So, they were kids. So, dermoscopy. Which one? We have dots in both these cases. This one, because it's brown. Okay, brown and bigger. Yeah. In this case, they are gray and smaller. So, yeah, correct. That one is ashy dermatosis. Perfect. You are too good. The second group of conditions, pigmented reticular patches on the back. Here, the differential diagnosis is only one. Frictional melanosis and macular amyloidosis. But without dermoscopy, it's nearly impossible to say which one has... This one, what? This one? Amyloidosis. Okay. And this one? Do you agree? Why? You have to teach me. Why? Okay, we will see. We will see. I don't know. I don't remember, honestly. Okay. Let's see the dermoscopic clues. Okay? In frictional melanosis, we have structureless brown areas. Structureless brown areas. In macular amyloidosis, we have these nice structures typified by a central brown dot or a central white globule with a peripheral pigmentation, peripheral stria. It, you know, they look like the spoke wheel like areas of BCC, huh? To remember. Okay. So, you told me that one. I'm afraid that you are right, but I don't remember. Let's see. It's too good, it's too good. What do we have here? Just structureless brown areas. On the other hand, here we have a central brown dot and peripheral pigmentation, okay? So, he's right. Frictional melanosis on the left and macular amyloidosis on the right. But just for you, because for me, it's impossible to make the differential diagnosis on clinical ground. Okay, the third group of conditions. Confluent pigmented macules with white scales on the trunk. Here, the differential diagnosis is between pityriasis versicolor and the Gauguin-Carteau syndrome, okay, which is not so uncommon, okay. Even here, of course, we can have an idea, I agree here, but let's take a look at dermoscopy. In pityriasis rosea, we have a structureless brown pigmentation, okay, and we have white scales in the skin furrows. Why? Because in the skin furrows, there is a higher humidity, and the fungus loves humidity, okay? So we have scales in the skin furrows. In the Gauguin-Carteau syndrome, we have this cobblestone pattern, so these polygonal brown globules, okay? And also white scales. Perfect. So I think this is easy. Which one is pityriasis versicolor? Yeah, we all agree. Okay, and it is, indeed. We have brown structureless areas and scales, white scales in the skin furrows. On the other hand, in that case, we have the cobblestone-like pattern, okay? These polygonal brown globules, okay? Great. And another condition, another scenario, pigmented patches of the crasis. The differential diagnosis here is between terra firme forma dermatosis, okay, which is a keratinization disorder, okay, and dermatosis neglecta. So the patient doesn't like to wash, let's say, okay? Okay. Let's take a look at dermoscopy. They are similar. We have brown scales. In terra firme forma dermatosis, we have a more regular scales, which are, you know, the scales are polygonal and arranged in a mosaic pattern. On the other hand, in dermatosis neglecta, they are more irregular. I call them cornflake-like brown scales, okay? They are not polygonal. Okay. So which is the dermatosis neglecta? Right? Good, too good. Are you sure? We can confirm our diagnosis, yes, because here we have very regular brown scales, polygonal, and on the other hand, we have these cornflake-like brown scales, irregular scales, okay? So we can confirm it. Of course, we can also, you know, wash the skin, but it's not nice for the patient. Okay. Yeah, but you know, it's not nice. So this is the flow chart. Of course, we can have a diffuse pigmentation, so we have to think about pityriasis versicolor or urticaria pigmentosa, okay? Then we have other conditions characterized by dots, so lichen pigmentosus and Nashi dermatosis, and then we have these peculiar patterns in the other conditions, okay? Perfect. Now, let's move to face. Pigmented facial dermatosis. Here, it's very difficult. Now you have to tell me the diagnosis. Which one? This one. This one is ochronosis. Why? Why? Okay. And this one? Melasma. Okay. To me, everything looks like melasma. Okay, and here? Here it's easier. Ochronosis, which one? Yeah. Okay, let's take a look at the dermoscopic clues of these conditions. we basically have three groups of conditions, okay? The first one includes facial pigmented dermatosis characterized by dots, okay? And we have three conditions. Ashy dermatosis, in which the color of the dots is blue, okay, blue-gray, and the arrangement is around the follicles. Then we have lichen pigmentosus, the same pattern, but the color is different, it's brown. So brown dots around the follicles. And third, real melanosis, which is pigmented contact dermatitis. We have still gray, blue, or brown dots around the follicles, but the main clue is the presence of intrafollicular brown dots. Why? We have a pigment leakage through the follicle, okay? So this is the clue. Then we have the second group of conditions typified by pseudo-network, okay? So structureless brown areas with sparing of the follicular and eccrine ostia, melasma and nevus ovata. In melasma, of course, the pigmentation is more homogeneous. In nevus ovata, it's less homogeneous, but the main clue is the presence of the, let's say, eccrine ostia obliteration, eccrine ostia pigmentation in nevus ovata. We don't see the eccrine ostia pigmentation in melasma. And then the third group, which includes just one condition, exogenous ochronosis, which is typified by these very nice circles and semicircles, okay? Which corresponds to the presence on histology of, the banana-like shaped body, okay? So these thick collagenic fibers covered by ochronotic pigment. Okay, this is the summary, huh? Okay, circles and semicircles, just one diagnosis, exogenous ochronosis. Pseudo-network, melasma or nevus ovata. In nevus ovata, we have eccrine ostia pigmentation. And then the dots. Intrafollicular is typical for real melanosis. On the other hand, perifollicular distribution is typical for ashy dermatosis and lichen pigmentosus. The color makes the difference, okay? Okay, so you told me that this is exogenous ochronosis and that one melasma. Okay. I don't know, I don't remember. Let's see. Okay, do we see ochronosis? Do we see any circles and semicircles? I don't see any. No. We have dots, okay, which are very dense, but these are dots, okay. Perifollicular distribution. The color is blue, blue-black. Huh? So, ashy dermatosis. I think so. Let's see. Ashy dermatosis. Good, good. Okay, and this. You told me melasma. It looked like melasma, okay, I agree. Lichen pigmentosus, yes, could be, because we have brown dots around the follicles, but take a look here. Real melanosis, because we have dots, intrafollicular dots, inside the eccrine ostia and the follicular ostia. So this is real melanosis. Much easier with dermoscopy. Huh? This is a nightmare, guys. This is a nightmare because facial pigmentation, may be due to a lot of diseases. But on dermoscopy, of course, coupled with clinical data, we can, improve the diagnosis. Here, I agree with you. This is exogenous ochronosis because we have these tiny brown-black papules. So yes. But on dermoscopy, I can have, the confirmation because we see these, circles, semicircles, so we can confirm our diagnosis. Okay. And then here, do we have dots? No. Do we have circles? Yeah, melasma. Because we have a pseudo-network. We have a homogeneous brown pigmentation. Great. Okay, let's practice. Here, ochronosis, ashy dermatosis. It could be everything, come on. Okay, let's take a look at dermoscopy. Real melanosis, perfect, because we have intrafollicular dots. Good, very good. This one is simple. Exogenous ochronosis, are you sure? Are you sure? Huh? Do you see any circles and semicircles? No. We have brown pigmentation with osteoobliteration, okay? So, correct, it's nevus sovota. And we have to remember that nevus sovota may also, be present, may also arise in old age, and it may also be bilateral. So it's not so simple, the diagnosis. Okay, perfect. And this one, this is an African patient, very dark skin. This is difficult. This is difficult. But what do we see here? We see some bananas. Huh? Yes, exogenous ochronosis. From a clinical point of view, it's very, very difficult. Exogenous ochronosis. Then, white. Okay, white may be due to fibrosis, dermofibrosis, or lack of melanin, reduction of melanin. Perfect. So, this is the basics. So, the majority of hypopigmented dermatosis present with unspecific white succulus areas, okay? We have to analyze the margins of the lesions, okay, if they are sharp or not, the shade of the white, but it's difficult, but most importantly, we have to see the additional dermoscopic features, okay? Let's see, achromic pityriasis versicolor. I already told you that the main clue is the presence of white scales in the skin furrows. But we also have perifollicular white depigmentation, okay? Because the fungus has a tropism for the follicle. So even if we treat the patient, this pattern remains. So we can also do a retrospective diagnosis. Okay, idiopathic gutted hypomelanosis, okay? We have, the white areas, the margins may be sharp or not. The main clue is the presence of, perilesional pigmentation, okay? Because, this is due to the sun, so we have depigmentation and pigmentation. And also this cloudy sky-like appearance, which is characterized by different shapes in the context of the lesion. Okay, these are the two clues. Cloudy sky-like appearance and the peripheral pigmentation. Then vitiligo, of course, vitiligo. The main clue are the presence of perifollicular pigmentation and white hairs, okay? Great. Post-inflammatory hypopigmentation. Here, the main clue is the presence of remaining findings of the original dermatosis. For example, what could it be, this? Psoriasis, because we still have uniform dotted vessels. And this one, do you know the white starburst pattern? No, it's an inflammatory condition. So, prurigo nodularis. In prurigo nodularis, we see the white starburst pattern, which remains after the healing of the lesion. Okay. Cutaneous lichen sclerosus. This is very important. The main clue, of course, the white is brighter because, it is due to fibrosis, okay? The main clue are the presence of follicular plugs due to the presence of follicular hyperkeratosis, but also these, purpuric spots. These are not seen in morphea, for example. Okay, so a flow chart. Sharp edges, it may be vitiligo. In vitiligo, we nearly always have, sharp edges. And in post-inflammatory hypopigmentation, we have blurred, okay, ill-defined edges. These three conditions may have ill-defined and well-defined margins, okay? So the clue are the presence of follicular plaques and hemorrhagic spots for extragenital lichen sclerosus, white scales in the skin furrows and perifollicular hypopigmentation and achromic pityriasis versicolor, and in idiopathic gutted hypomelanosis, perilesional patchy pigmentation and the cloudy sky-like pattern, okay? Post-inflammatory hypopigmentation, we have to look for remaining findings of the previous dermatosis, and then vitiligo, perifollicular pigmentation, and white hairs, okay? Okay, let's see some examples. Now, can you tell me which one is vitiligo? This one. Do you agree? Yes, this one. Do you agree? No, okay. Okay. Okay, this is not vitiligo. What is this? Morphea. Okay. So, this one, yeah? This one, and this one? We have perifollicular pigmentation, vitiligo. And here we have follicular plaques. So, you're right, this is lichen sclerosus, and that one is vitiligo. Perfect. And here, idiopathic gout hypomelanosis, which one? This one? No? And that one? Lichen sclerosus. Ah, it could be, could be, could be. Let's take a look at dermoscopy. So here we have perilesional pigmentation, so idiopathic gout hypomelanosis. And then, yeah, porokeratosis. Come on, during the winter, we don't see inflammatory lesions. We see hypopigmented lesions, okay? So we have to rely on the remaining findings. So the peripheral keratotic tract with a double free edge. Great, great. Okay, here, now you have to tell me the diagnosis here. Vitiligo? I didn't get anything. Okay, pityriasis versicolor, and that one? Lichen sclerosus, this one. Now? No? Psoriasis on the right, okay, because we have dotted vessels. And here, follicular plaques. So Nisha is right. Lichen sclerosus, lichen sclerosus. Brava, brava. Okay, and this, Jesus. Leprosy, because we have a reduction of skin appendages. Huh? Okay, great, 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 great. So yellow, just very few words about yellow, because yellow is due to the presence of lipids in the dermis. So, which are the conditions? Xanthogranuloma, we have lipids, okay. Histiocytosis, we have lipids. Xanthomas in general, we have lipids. Necrobiosis lipoidica, we have lipids, of course, associated with the vascular pattern I told you, and also orange areas, okay? But the most interesting condition to me is xanthogranuloma, okay? Because sometimes may be mistaken for another condition, okay? Of course, the pattern is different from Spitz nevus, is different from pyloma trichoma, and so on. But sometimes we may mistake it for mastocytoma. Mastocytoma, because also in mastocytoma we can see yellow. We can see yellow. But which one do you think is xanthogranuloma? This one, correct, because the yellow is yellow, more intense, and we also have orange, okay? On the screen also that one looks orange, but it's brown, okay? In xanthogranuloma we have orange, okay? On the other hand, in mastocytoma we have the pigmentation of the basal cell layer, so we see brown. So the color is different, brown and orange, and of course the yellow is brighter in xanthogranuloma. Okay. Purple. Just a few words on purple. Of course, purple is due to the presence of erythrocytes in the dermis. Okay. One of the applications may be vasculitis versus capillaritis. Of course, we can have our idea. Okay. Let's see on dermoscopy. In capillaritis, the one on the right, we have red-focused purpuric dots and globules. On the left, vasculitis, we have a violaceous, okay, purple background with some red spots inside, okay? So it's different, okay, the pattern. But the best application, in my opinion, of the purple in dermoscopy is this one. Do you have any idea about the diagnosis here? Leishmaniasis, okay, or lymphoma, sarcoidosis, yeah, okay. We have orange, but we have purpuric spots. There is a disease. No, no microbiosis, because we don't have the vascular pattern. And we have the purpuric spots. There is a disease characterized by purpuric spots, by definition, especially around the eyes. What? Amyloidosis, amyloidosis. This was nodular amyloidosis. Okay, you know that in amyloidosis, we have hemorrhages. Okay, even in this case, for example, this one came to me for these papules, okay, and on dermoscopy, there were, of course, orange areas, but purpuric spots. So also this was a systemic amyloidosis, okay? So you can see that dermoscopy may be very helpful. We always have to correlate dermoscopy with histology, of course, but it's very, very helpful. So now I would like to do this experiment. I don't know if it, will be realized, but okay. Which color do you see here? White and gold. Black and blue. Do you really see white and gold? Really? Huh? Is there anyone who sees white and gold? White and gold. You must have some problems. I see blue and black. Agree on what? White and gold. Blue and black. It's unbelievable. There are some people who see white and gold and some other people who see blue and black. The reality is blue and black. The reality is blue and black. You have some problems. But this is to say that colors are very important, but we have to focus on what we see. Because sometimes there is someone who says, no, it's not orange, it's yellow, so it's not simple. Come on, it's not simple. But if we use a standardized approach, we can improve a lot of our diagnostic power. So, but the truth is black and blue, so you have some problems. These are the references if you are interested in this topic. This is my city, Udine, and my region, very nice. Every year we host several fellows from outside Italy, and so if any of your young colleagues is willing to come to us to learn some dermoscopy, we are very happy to host you. Okay, bye-bye.